Get started here. So thanks everyone for coming, and thanks to those who are logged on online. Welcome to September, the first post-summer medical grand rounds. So I want to thank Iris Laycock for organization, Mitch Wine, who's not here, and all the rest of the academic affairs staff at RVH. So we're very happy to welcome our second talk on the oncology series this year. We've been very blessed and lucky to develop this world-class cancer center right in Barrie. And with it has come some young, talented, brilliant oncologists to complement our existing amazing team. And Dr. Zhang is one of those brilliant young guys that we've been able to recruit up to Barrie, which is a coup for sure. So I'm going to do his intro because I don't want to forget something. So completed med school and residency training in Rad-Onc at the U of T. With his fellowship at the Odette Cancer Center, and he specializes in central nervous system tumors and stereotactic body radiotherapy. His clinical interests are bringing advanced radiotherapy technology and techniques into practice in an evidence-based manner. He has first authored 18 peer-reviewed papers in the leading Rad-Onc journals and has received best paper awards at regional, national, and international conferences for his work in stereotactic body radiotherapy and spinal mets. He is excited to be part of the team at RVH, where his practice is focused on central nervous tumors, GI cancers, and thoracic cancers. So I'd like everyone to put their hands together and welcome Dr. Zhang.
All right, so thanks, Dr. Martin, for the very nice introduction and for your attention today and the invitation to speak. So I don't have any conflicts of interest. So hopefully in this short presentation, I'll define oligometastases as a subset of patients with stage 4 metastatic cancer and review an opportunity for metastases-directed treatment in this type of setting, and specifically the role of radiation. And through this, I'll also review the importance of the control of one of my primary focuses, so CNS tumors for brain and spine metastases, and how we achieve this with modern radiotherapy. So I know we have quite a bit of diversity in the audience today, but when we stage cancers, solid tumors, we generally tend to stage them as stage 1, 2, 3, and 4. Stage 1 to 3 being localized cancers that tend to be treated in a curative manner, and stage 4 cancers as those that have spread beyond the regional borders and are metastatic, where the intent of treatment is to delay further progression. However, we know that stage 4 cancers aren't a single entity, and we see a spectrum amongst those with stage 4 cancer. There's a difference between those with limited metastatic disease, so maybe only 1 or 2 metastases, compared to those with widespread metastatic cancer. And so it's thought to be an intermediary state of oligometastases, which we consider as less than or equal to 5 metastases, in between that of localized cancer and widespread metastatic disease. And in this type of setting with oligometastatic cancer, there's a potential opportunity whereby treatment of the oligometastases may confer disease and also survival advantages. So this was first described by Hellman and Weisselbaum early in the 90s, where they thought that these tumors biologically represented disease that was early in the chain of progression with metastases that are limited in the number and the location. And nowadays with better imaging, so better access to PET, for example, disease-specific PET scans, and also better access to MRI, we're able to better identify patients who may have oligometastases. And really this is a radiographic description. We're still learning a lot more about biomarkers to help identify these patients. And so really the question is there a benefit to metastases-directed treatment, either through surgery, ablation, or even radiation treatments? And decades ago, we would really question ourselves for treating metastases in a more ablative setting, because the thought was that these tumors had to get to, for example, liver spreading to the lung through the bloodstream or the lymphatic channels. And really, that perhaps represents the tip of the iceberg. But nowadays, with better imaging, we're better able to identify patients who have limited spread and potentially are amenable to more ablative treatments with the goal of improving endpoints like overall survival, progression-free survival. So this is a nice paper by Dr. Guckenberger, which describes nowadays what we're seeing in the oligometastatic paradigm. So we're not only seeing those with oligometastases as a single entity, but we're also describing certain phases at which we see this. So de novo, meaning right at the diagnosis, we identify less than 5 metastases. Those with oligorecurrence, So those that have definitive or curative intent treatment and then recur in a limited fashion, so defined as oligorecurrence, and then oligoprogression. So if someone has widespread metastatic disease, but only a few lesions progress. So we're really creating more nuance in this sphere and describing when this progression occurs. So in the oligometastases realm, it's perhaps been nowhere better described than in the surgical papers that address liver metastases and colorectal cancer. And surgeons have been practicing this for decades, whereby although patients with metastatic colorectal cancer have liver metastases, we do targeted treatments and surgery to resect those liver metastases. And it's actually shown to have improvements in survival outcomes with metastatectomy, so surgical resection of liver metastases, although these patients have stage 4 disease. And so in other spheres, with colorectal oligometastases, if they're not able to be resected, we consider radiofrequency ablation. And this is just another example of a trial which showed that by targeting these sites of localized metastases, in this study they included those with up to 10 lesions, that by including targeted treatment to metastatic disease, the survival was improved compared to just systemic therapy alone at 5 years and 8 years. And previously in those with stage 4 cancers, these are endpoints which we wouldn't even consider in terms of outcomes at this time. So for those unfamiliar with radiotherapy, I'll really describe what is external beam radiation in this for the rest of this talk. So external beam radiation basically is ionizing radiation that is targeted towards certain areas in the body. When we give the radiation, we plan the radiation using a CT scan for planning to what we call map the areas to treat. We fuse these with diagnostic imaging that can help guide us to contour the target, mark out the target, and importantly, mark out areas that we don't want the radiation to spill to. The image on the left is one of our linear accelerators. So it's a machine that rotates around the patient, delivering the radiation beam focused at the target. And so when the patients are on the treatment bed, we have a small cone beam CT unit, which allows us to get a snapshot of that patient in the treatment position to ensure that we're hitting the target. And when we're planning, we use MRI and CT as really guidance in specific, depending on the area of the body that we treat. Conventionally, the role of radiotherapy in those with metastatic disease was really with the intent of palliating symptoms, so improving pain, slowing down bleeding. And the treatment was generally quite simple, really. If you see the two orange arrows, we generally, in the example of spine metastasis here, we generally give two beams, one coming from anteriorly and then one posteriorly, and they meet to intersect and give a low dose homogeneous dose of radiation with the intent of palliation of symptoms. More recently, we have the technology and the experience and also the evidence to guide treatment with stereotactic body radiation. So this is much more advanced radiation in the sense that when we mark the areas to treat, we have to be careful with avoiding specific aspects and normal body anatomy that can be sensitive to radiation. And then also have an understanding of the disease biology in terms of where the subclinical extent of the disease is. And so we use MRI, CT scans to guide how we mark out the regions to treat and importantly, the areas to avoid. And you can see on panel C on the far right, when we create these radiation plans, they're highly conformal. So the high doses only go to the areas that we want to treat. In the esophagus on panel C, I don't think you see my cursor, but on the top right, you can see that pink isodose line curving away from that esophagus to spare the esophagus. Right smack bang in the center is the spinal canal, which we want to avoid from overdosing. So really, this is a more sophisticated way of doing radiation. It's a much more involved process as well, and it's much more resource intensive. And the goal here is not only for the palliation of symptoms, so such as improving pain, improving function, but also for tumor ablation. And so for this is an older picture, but in this type of setup for how we have the patient on the treatment table for SBRT, the patients need to be near rigid. And when we do our imaging while the patient's on the bed, we do an image before we start the treatment, midway through the treatment, and also towards the end of treatment to ensure that the patient's anatomy is within the range of tolerance that is acceptable. And we really have very minimal tolerance of movement in this case. And for spine in particular, we limit motion to 1 millimeter and 1 degree of rotation. And so we have to make sure that these high doses are going to the areas that we deliver. And therefore, it's a very resource intensive process made possible by the technology advancements that we're seeing in the radiation sphere over the past decade or so. But what really guides our treatment is randomized clinical trials. And so this was a large clinical trial led out of London by Dr. Palma, which looked at those with oligometastases, so those with metastatic cancer who spread in 1 to 5 regions, to see whether addition of SBRT to those metastases improves outcomes compared to just standard of care, which usually is systemic therapy alone. And so they assigned patients in a 1 to 2 fashion. So 2/3 of patients got SBRT to all areas of metastases. 1/3 of patients got the standard systemic therapy, and they found that by giving SBRT to all of those areas of metastases, we actually improved their survival and improved progression-free survival as well, which is a composite endpoint of when cancer recurs, including that of if the patient survives during that time frame. And so it almost doubled progression-free survival and improved overall survival by about 13 months. In the oligometastases sphere, however, we really do need histology-specific trials. So, for example, lung cancer behaves differently from breast cancer, from prostate cancer. The disease biology is different. Systemic therapy options are different as well. And so we really need to match these trials with the biology of these diseases. And so this was a trial by Gomez that looked in lung cancer specifically to see what would happen if we added metastases-directed treatment, either surgery or radiation, after systemic therapy in the consolidative setting. And this trial showed that there was a significant improvement in progression-free survival, so it nearly tripled with the addition of treating those metastases, and overall survival over doubled by treating the metastases. And so radiation plays an important role based on these clinical trials. So we really divide SBRT SBRT really refers to, and it's a little bit of nomenclature here, but the SBRT refers to ablative radiation that tends to take place in 5 or fewer treatments extracranially, so not within the brain. And so here at the RVH, at the top 4 panels, we've been starting liver SBRT. Bottom left, we've been doing bone SBRT. The middle at the bottom row, we've been doing adrenal SBRT. And on the bottom right, probably what we've been practicing most often is lung SBRT as an alternative to surgery in early stage non-small cell lung cancer. So it's quite an involved process. So just at the top, for example, with liver SBRT, there's a lot of considerations to be made. Firstly, we have to get the right contrast timing. We have to get an understanding of how the liver moves with respiration and how to deliver our radiation so that it encompasses the target, to ensure that we hit the target, and also an understanding of how much radiation dose the normal liver can take so that patients don't run into toxicity. On the bottom left, for example, when we do bone SBRT, we have to take considerations as, is the disease only this lytic lesion here, or is there subclinical extension of the disease? How does MRI help us? How do we make sure that the patient doesn't move on the treatment unit? And similar considerations to adrenal SBRT on the bottom panel here and on the bottom right panel here, where we really have to be considerate of the radiation dose given to the gastrointestinal structures, which can be quite sensitive, and also the chest wall for the lung. Within the brain, SBRT is commonly known as radiosurgery, and this is based on the history of how patients used to receive radiosurgery, where a neurosurgical frame was placed on a patient's skull and a single fraction was given on specific units. Nowadays, we can treat patients. These days, we treat patients with a mask, so there's no longer an invasive frame that's needed to be placed on a patient's skull. We can give 1 to 5 treatments with the goal of targeting brain metastases in a very focal way. And in this way, we spare the normal brain tissues, which can be sensitive, especially in our elderly population, whereby those radiation doses to the normal brain tissues, and I'll talk about this a little bit more in the presentation, can cause significant cognitive impacts, such as short-term memory deficits, and really reduce the speed of thinking. So to summarize so far, I've really described a radiographic oligometastatic state. We're learning more about this, and perhaps there's a role for serum markers as we get more data from the clinical trials. There's potential opportunities not only in those with de novo oligometastases, so those presenting with a few metastases, but maybe in oligoprogression and oligorecurrence. And I've shown that through the clinical trials, not only in surgery, ablation through our interventional procedures, but with radiation as well, that targeting these metastases has the potential to improve key endpoints like overall survival and progression-free survival. But what does it mean from a patient perspective when we treat these areas with ablative radiation? How can we improve the symptom control that we previously gave these patients, that we previously delivered with conventional external beam radiotherapy? And as patients are living longer these days owing to better systemic therapies, perhaps by targeting these areas with SBRT, and especially in critical areas, perhaps we can improve the durability of the symptom control and also prevent these patients from running into devastating complications. So I'll go on to the last point of my objectives, which is to review the importance of control of brain and spine metastases and how this is achieved with modern radiotherapy. So I've mentioned this and I've alluded to this, that patients in general with metastatic cancers are living longer. And this is usually because the survival is dictated by the systemic disease. And these days with novel treatments like monoclonal antibodies, immunotherapy, and targeted therapies, patients are living longer despite having metastatic disease. And along with this aggressive management of oligometastases. Now, nearly 2/3 of patients with solid tumor cancers will develop bone metastases, the majority of which are in the spine. You can imagine this leads to pain, can lead to fractures, causing mechanical and biologic pain, and it can also lead to devastating complications like spinal cord compression, which is when the tumor is pressing on the spinal canal, leading to weakness, leading to troubles with bowel, bladder, walking, sensory deficits. So this is a devastating complication of spinal metastases that we're hoping to avoid. Just to give you an example of how patients are doing better with novel systemic therapy, I don't think you need to look much further than metastatic melanoma, where the advent of targeted agents and immunotherapy has really improved median survival over the years compared to just cytotoxic chemotherapy alone. And we're seeing drastic improvements in survival with these novel agents. So we're recognizing that treatment of not only symptomatic but also asymptomatic spinal metastases is of increasing clinical importance. And really, this is very multidisciplinary in that radiation isn't the only option for these patients, but the systemic therapy plays an important role, surgery and interventional procedures also. And so we have to work very closely with our colleagues to develop guidelines into how to approach these patients in a meaningful way. Within the spine in particular, from a radiotherapy perspective, there's only so much radiation that the spinal canal, which is our primary dose-limiting organ here, can see during a patient's lifetime. And so if a patient is expected to live perhaps even years with metastatic cancer, we need to start thinking about the durability of the pain relief and the durability of tumor control. So if we give a patient conventional radiotherapy, they have a response for a couple of months, but the disease is otherwise stable, we run into issues with reirradiation and third-time reirradiation because of the fact that the spinal cord can only see so much radiation during that patient's lifetime. So really giving a high dose of radiation with the intent of long-term control at the outset is quite important in select patients. So I showed this picture previously of the traditional way of doing radiation to the spine, and there definitely is a role for this these days, and it's a very important component of patients' care. And I won't say that all patients with spine metastases need SBRT, but really the data that's guiding this and the evidence that guides this treatment is quite outdated. These are low doses that we use. There's no avoidance of normal tissues within this field. There's minimal short-term toxicities, which is great for our patients that may be quite unwell, but the pain control is partial and transient, and we don't usually consider tumor control in this setting rather than just the palliative or the pain endpoint. And I've shown this slide previously of stereotactic radiotherapy. Again, it's very conformal. We carefully mark out the areas to treat, importantly, the areas to avoid as well. When we plan these patients with radiation, the beams are going all around at 360 degrees to really focus in and hone in on that target to give as much radiation as possible while sparing these critical structures that may only lie a few millimeters away, to spare the esophagus from the radiation as well to minimize toxicities. And so with conventional radiation, really just these clinical trials that were accumulated as part of meta-analyses from nearly 40 to 50 years ago that guided our previous treatments. This was a time when MRI was barely in clinical use and the systemic treatments were quite limited in that time. And over the years, with the advancements, these patients are living longer, and so we do have to consider the durability of the outcomes of interest, so pain and local control. When these meta-analyses looked at pain response, you can see when the time points at which pain response was assessed. So sometimes 3 months on the bottom right, sometimes even just 1 to 2 months, and whether these endpoints are relevant for our patients now who may live a year or two, or even longer with metastatic disease, we really have to take that into consideration when we're deciding on the treatment that patients need. So this was this was a randomized international clinical trial led by my fellowship supervisor out of Sunnybrook, and included patients in Australia as well, which was the first trial that really compared SBRT, or modern conformal high-dose ablative radiation, to conventional external beam palliative radiotherapy, so the homogeneous radiation. It randomized patients with spinal metastases. Half of patients got SBRT, half of patients got conventional radiotherapy, and the main endpoint of interest here was how can we improve the patient's pain, so the complete pain response rates, and also the durability of the pain response. It's a little bit hard to see here, but I'll highlight these two main endpoints, which is the 3-month complete pain response rate and the 6-month complete response rate. And the complete response basically means that at the site of treatment, the patient had 0 pain, and also they didn't need an increase in the oral medications to help with that pain. And so really it's quite an objective measure of did the treatment work or not. And in this study, it showed that a significantly greater proportion of those who had SBRT had a complete pain response compared to conventional external beam radiotherapy, so 35% compared to 14%, and an even greater proportion had at least some pain response. And this was durable to the 6-month mark. And this 6-month mark really wasn't considered in those trials included in the conventional external beam setting. And so this study concluded that spine SBRT was superior to conventional external beam radiotherapy with the endpoint of complete pain response rates, which was durable to 6 months. And this was the first phase 3 randomized control trial to show that these dose escalation techniques with modern radiotherapy improves the pain endpoint. When I was a fellow, I took a deeper look into these data to compare the other endpoints of interest, so local control of these tumors into the 1 and the 2 year mark. And we found that there was a significant improvement in the local control rates, where only 15% of these tumors progressed at 2 years compared to nearly 40% with conventional radiotherapy. And the rates of reirradiation were much lower with SBRT, which adds more guidance to the benefits of SBRT in a well-selected population. And so with these data, it has added to the NCCN guidelines to suggest that stereotactic radiation is suggested for those patients with potential oligometastases, or in those tumors that may be less sensitive to radiation or radioresistant, so certain cancers like renal cell cancers, melanoma, colorectal cancers. Just to give you an example, this is a patient treated with SBRT. So you can see on the left panel before radiation, on the left side of the screen, so the right side of the vertebral body, you have a renal cell metastasis. It's pushing on that spinal canal column. It's quite extensive. There's disease that's extending outside of the bone. We gave it conformal radiation of SBRT doses. And even at 24 months later, in someone that has risk factors for progression, meaning that the tumor is already pressing on the spinal canal, it's extending outside of bone, there's a lot of bad features to begin with, and that this is a renal cell cancer, which is traditionally thought to be resistant to radiation. At 2 years, we have control of this lesion. And in fact, it's retracted a bit, and the pressure on the spinal canal has improved. So we have randomized control trials that demonstrate that pain response, tumor control, and the durability of both are improved with SBRT compared to conventional radiotherapy. But how do we decide who needs which? Not all patients need SBRT. SBRT is very resource intensive, and there are limitations. Patients quite commonly are in discomfort, and lying on the treatment unit can be difficult for patients. And these treatments are very intensive. You can imagine trying to immobilize someone who's in a lot of pain is to be quite difficult. So a few considerations that we have, we consider the prognosis, we consider the systemic therapy options, and then we consider features where conventional radiotherapy is associated with poor response. So those with epidural disease, those who've had previous treatments, those who have radio-resistant disease. And we also consider working with our surgical colleagues and interventional radiology colleagues, whereby if there's instability in the spine, we consider integrating those and assessing these patients in a multidisciplinary setting. So I showed one of these images previously, but just to give you a sense of how involved SBRT is, for patients they need to be near rigid, and so we accept a 1 millimeter translation or a 1 degree rotation as our threshold to have the patient in treatment position. And so patients are usually in these vacuum bags, so there's very little room for movement. If you can imagine, getting into a bag is quite difficult for those with pain. And so on the treatment unit, we get a cone beam CT scan, which lets us match the patient's anatomy to the planning images to ensure that the target is being treated, and as importantly, the healthy tissue is avoided. When we contour or mark out the areas to treat, we need to be sure of where the spinal canal runs. And with the spinal cord being our dose-limiting structure, if we give a toxic amount of radiation to this, we can cause an iatrogenic injury to the spinal cord, which can cause weakness of the legs, paraplegia, issues with bowel and bladder function. So we have to be very careful in planning this. And so we rely on our radiology colleagues to have this imaging to match and help us plan. And when they're on the unit, if you can see on the picture on the right, we use that cone beam CT scan to ensure that the bones are aligned with how we planned it, so that the high doses are going where the high doses are intended, and the low doses and what is sparing in terms of the spinal canal is being avoided like we planned. And so the immobilization has to be near rigid. Treatment planning integrates a volumetric MRI used for fusion. CT myelogram can be used if someone has a contraindication to MRI. Radiation is delivered with image guidance and this very small correction threshold. So we only allow 1 millimeter and 1 degree of movement. And when the patients are on the treatment bed, they're on a robotic couch with 6 degrees of freedom, which allows us to adjust the patient position within that correction threshold so that we know that these high doses are going where they intend. As I said previously, there's still a very important role of conventional radiotherapy. One of these reasons is that with SBRT in particular, we see a complication in the with iatrogenic. We see an iatrogenic complication, with vertebral compression fractures, and so this is further fracturing of the bone as a result of treatment itself, and it's a 10% risk. And so on the pictures on the right, you see that this patient in the spinal column has a baseline fracture. This patient received 24 gray in 1 fraction, and we generally tend to do this in 2 to 5 fractions nowadays to lower the fracture risk. And over time, you can see the vertebral body collapsing as a result of treatment itself. And this can cause a lot of pain for patients. And that pain can really limit their function. And then the other consideration down the road is, with that pain, can they get through their systemic therapy, and whether there are delays of that because of the pain. And so we really have to work with our colleagues in spine surgery and interventional radiology to be able to address these fractures in a timely manner to keep their cancer treatments on track. Another potential complication of treatment is plexopathy, so irritation of the peripheral nerve roots in the lumbosacral region and also in the brachial plexus. The rates of plexopathy with SBRT are about 3%, but I've seen really devastating ones when they happen in terms of loss of arm function, a lot of neuropathic pain when this happens. So we have to be very careful and selective for these patients. So spine SBRT allows for durable pain and tumor controls, and in general with fewer fractions and with sparing of normal tissues with ablative doses of radiation. An interesting point in the Canadian trial that I showed from before that compared conventional radiotherapy to SBRT was that one of the quality of life indicators, which was financial health, was actually improved with spine SBRT compared to conventional radiotherapy. The reason being is that spine SBRT can be given in 2 treatments, conventional radiation usually in 5 treatments, though it can be given in a single treatment. This means less visits for our patients, and especially for our patients that can come from a distance, that is an important consideration for these patients. Patient selection, I've mentioned, is critical, as well as awareness of potential complication and when to ask our colleagues to intervene with interventional or surgical procedures. And again, this still is an important role for conventional external beam radiotherapy, especially in those with poor prognosis, poor function. But as we see that patients are living longer with metastatic disease, we should really be considering spine treatments in the right clinical situation. So here at the RVH, I started about a year ago, and the team had made a lot of progress before I started, but we started treating spine SBRT here now. This is a case that we did in the thoracic spine just a few weeks ago. There's a lot of logistical aspects of this with immobilization and how to get that patient on the table for that period of time without movements, and so requiring immobilization. And we're hoping to have this set up so we have a full SBRT spine program over the next little while, but we've already started treating some select patients. So the last topic that I'll just have a discussion on today is brain metastases. So this is when tumors spread from solid cancers into the brain. And we are seeing these with increased incidence. And again, this is because patients are living longer with metastatic disease. There's novel systemic therapy and also improved imaging techniques where we have ready access to MRI. And as a result, we're screening patients more, and we're finding those patients with multiple brain metastases and even with small brain metastases. And so in a space where there's not much room for tumors to grow without causing significant symptoms, the control of metastatic tumors within the brain is quite critical because neurologic deficits can develop even when these tumors are small. Within the brain, we think of SBRT, and the nomenclature is radiosurgery or fractionated radiotherapy, which is focal radiation within the brain. But there's strong upfront evidence for focal treatment in those that have up to 4 brain metastases. This is an area of ongoing work, and more recently, in a trial that was presented about 2 years ago, it's shown that even treating 15 spots in the brain with focused radiation does improve their cognitive and lower the risk of cognitive impairment and doesn't compromise the patient's overall survival. The concern with treating more where a patient has 15 metastases is, of course, the risk of the 16th or the 17th spot does increase with that compared to if someone just has 1 or 2 spots that we're treating. And therefore, access to MRI and ongoing surveillance of these patients are critical. The traditional standard 20, 30 years ago, where we did not have the techniques to treat these patients, was with whole brain radiation. I have a few pictures in the subsequent slides to describe this. But this is becoming less and less favored. There are situations where we do give whole brain radiation where there's extensive disease or leptomeningeal disease. But the concern with whole brain radiation is that a lot of the normal brain tissues are seeing that radiation dose, and especially in our elderly population, there is a lot of concern with the levels of fatigue, the cognitive impairment that develops in these patients, and especially short-term memory that can affect quality of life. And as well as this, with the modest doses that we use when we have to treat the whole head, there's generally a lack of tumor control. And in some diseases, namely melanoma, where the systemic agents aren't guaranteed to work in the brain, it's even led to the questioning of use of whole brain radiation altogether. I will mention that part of the reason why radiation is indicated in brain metastases is that a lot of the systemic agents or the drug treatments don't penetrate the blood-brain barrier. And although it can work in the extracranial disease, radiation, apart from the doses that we use and dose considerations, does not tend to discriminate amongst the cancers that spread to the brain. So just on that topic, there are certain cancers where novel treatments have been developed, so targeted agents, drug treatments, oral pills that do have intracranial efficacy. So this red box just shows the intracranial response rate of certain targeted agents. For example, here, non-small cell lung cancers that harbor EGFR or ALK mutations. And it shows that these targeted agents do tend to work on the brain, sometimes even as high as 80%. However, it's not guaranteed, and in some drugs, some immunotherapies, this may be low, so we're about a quarter of patients, even though it may work elsewhere in the body, it does not necessarily guarantee a brain response. In other areas and other primary cancers, such as melanoma and breast cancer with HER2 targeted treatments, targeted agents to BRAF, and MEK inhibition, we do see that these do have intracranial efficacy, but again, it's not guaranteed. And with the concern of these lesions growing and causing neurologic detriments, it's really important to engage a radiation oncology team to see how these tumors should be managed and to see if there is a role for upfront management with radiation. So this is a patient that I saw a few weeks ago with a brainstem metastasis. She was young. She had her extracranial disease within the lungs, the liver was all controlled. There was this spot and I think 2 other spots in her case. In the middle panel, I've shown you just how we have traditionally given radiation for brain metastases. So it would be whole brain radiation. So the whole area of the brain gets treated with a low dose of palliative radiation, and it is all palliative. But you can see that there's little intentional dose sparing of the normal brain tissues. On the right, you see what we do here at RVH, which is fractionated stereotactic radiation. So it's much more focused. We're targeting these tumors. We rely on our colleagues in radiology to help us to identify these tumors because the MRI is critical. And so you can see the radiation doses that goes to the normal brain is quite spared. And so in this patient, if I'm treating this one spot, I'm worried about if I gave whole brain radiation, how much of the other centers of the brain would receive the radiation dose and the long-term effects. And especially if I'm able to get good control of that tumor safely with targeted radiation, perhaps I'm benefiting her. I may not necessarily improve that patient's survival, but if this patient does well over the next months, perhaps even a year or 2 years, then I'm sparing her from the cognitive impacts of whole brain radiation that does increase over time. And so in limited metastases, we do tend to recommend stereotactic radiation or radiosurgery to the brain. So there are a lot of considerations to be made, and I do encourage you to engage with the radiation oncologist because you have to understand the histology-specific biology, to understand the systemic therapy and the intracranial efficacy to see when radiation would be indicated, when to time this radiation with that, and how to potentially salvage. So you have to think ahead to if this tumor if the radiation doesn't work, how will I salvage this? Will it be surgery? Will it be repeat radiation? Or will there be systemic therapy that would work within the brain? The main complication that we see with stereotactic radiation to the brain is the risk of radiation necrosis, which is about 5%. So the panel on the right, you see a new brain metastasis in the left cerebellum that's developed. So this little white nodule, post-stereotactic radiosurgery, this has completely disappeared. However, with ongoing MRI follow-up, which we recommend on an every 3-month basis, there's a new enhancing nodule that's appeared. Radiation necrosis, which is just intense inflammation in that region, can very much appear like tumor recurrence. If we assume that this was tumor recurrence and re-irradiate this area, only to find out that this was transient inflammation, which would have settled down with some steroid treatment, then we could be exposing this patient to a lot of harm. And so there is a lot of consideration to be made in these cases. We do engage with our radiology colleagues and with our neurosurgeons to help manage in these difficult scenarios. So hopefully I've shown how ablative radiation has an important role, not only in those with oligometastases with the intent of improving endpoints like progression-free survival and overall survival, but can also improve quality of life measures and their durability with spine and brain metastases beyond that of conventional external beam radiotherapy. There still is a very important role for conventional external beam radiotherapy, and not all patients need SBRT or ablative radiation. And so this is a very important discussion, and I recommend to engage with the radiation oncologist. The data continues to mature in the role of SBRT in oligometastases, and histology-specific data, so lung trials, prostate trials, are much needed to help guide treatment. But we're beginning to see with good level 1 evidence how there is an important role in SBRT in this setting. At the RVH, we do have a comprehensive SBRT program. Most recently, within the past year, we're starting to treat liver SBRT and also spine. We hope to continue to add to this. I think the one site that we may be doing less of that we've started to do a bit more now is pancreas and the hepatobiliary system. But we're starting to engage with our colleagues to integrate that. And it's a continued area of growth as we accumulate the evidence to practice this type of radiation in an evidence-based manner. So thank you very much for your attention. I'd be happy to take any questions. If you're shy, I can respond to emails.
Thanks very much, Dr. Zhang. That was really interesting. I'm super excited that we have that expertise here now. It certainly seems like, shotgun versus sniper approach, and most of us would want a sniper if we had one. Any questions for Dr. Zhang? I think there's a couple online. I have some. Okay. I have one for you to start, a practical question. Obviously, as you said, they have to be perfectly still. But there seems like for a lot of patients, it is a preferred method, especially for spinal mets. Is there any procedural sedation ever done to facilitate keeping still for those ones that would benefit from tear attack?
Yeah, so it's a good question. And especially within the spine, we're getting more and more evidence to treat not only symptomatic, but also asymptomatic spinal metastases for the fear of progression. In terms of having the patient on the unit, we have some of our therapists here who do a tremendous job with coaching these patients to be still as best as possible. Sometimes the immobilization we use helps to keep a patient as comfortable as possible. We don't tend to use invasive sedation methods to have the patient treated. We sometimes can pre-medicate them. Subcutaneous opioids can help with the pain. Frankly, one of the important distinctions with spinal metastases in particular is really differentiation between the type of pain they're having. So whether it's biologic pain as a result of the tumor itself, or whether it's mechanical pain because of the spinal instability if that tumor causes a fracture. If they're in so much pain that they can't get onto the treatment table itself, it's usually the mechanical aspects of that pain. And so that's when we engage our neurosurgical colleagues to see if there's any minimally invasive procedure that they can do to stabilize the spine, then get them onto treatment afterwards. And so it's really a multidisciplinary discussion that takes place.
And how long would an average session take?
Yeah, so it's a good question. The way that we give radiation now is basically with an arc. So the radiation goes around 360 degrees, and a little bit of radiation is given at each degree to target that lesion. I would say for the on-table time, about 20-30 minutes, usually, and depending on how much motion we see in that patient, how many times we need to adjust that patient, it can be longer. Previously, when this was done 10, 20 years ago, or not 20 years ago, but about 10 years ago, at the centers that really pioneered this technique where we didn't have the arc treatments, it could be even up to an hour. And so patients would need a break during that time to get their treatment done.
And I agree with you. We have awesome technologists here who covers in the room. Any other questions? I got a couple more. There you go.
So you mean for a lot of drugs and stuff like that, we'll hold when patients are getting like FBRT lung or other tumor sites. For patients who are getting FBRT to brain, oftentimes they're on osimertinib, some drugs that watch entry into the blood-brain barrier. Is there any other drugs that we should be holding in that scenario? Do you guys try to hold all drugs while they're trying to get the SBRT, or just continue through?
Yeah, so that's a really excellent question. I think that's something that we're learning more about. For the oral tyrosine kinase inhibitors, we generally tend to hold 2 days before, during, and 2 days after. So like the EGFR, the ALK drugs. There's some oral agents where we do hold for a week. The ones to look out for would be Avastin, if they're on that, and cytotoxic chemotherapy. I think the one difficulty that we have right now in particular is with immunotherapy, and if that even needs to be held during. The risk is that when we're treating with such focused radiation and there's such intense inflammation around the normal brain tissues, could we be giving a super additive toxicity by combining those two approaches? And I think we're getting more and more comfortable with limiting the time off drug treatments, because we really want to minimize that, because it's so important for the extracranial disease. So we don't want to be, chipping away at specific areas just to leave other areas to not receive any treatment. So I think it's an area of ongoing work. But for the tyrosine kinase inhibitors, I think that's been quite well established to hold 2 days before, during, and after.
Is there any data for drug antibody conjugates? So previously you thought that TDM1 didn't enter the blood-brain barrier, and Camilla trial came along and kind of disproved that. Now TDXD for sure entered. Yeah,
so the HER2, the management of brain mets in HER2 positive breast cancer is really changing with those drugs. We don't have good data. I think we tend to practice out of an abundance of caution or so, but sometimes in situations where it's a critical location, it's causing symptoms, we tend to limit that time just to have an informed discussion with the patient. There's not really good data to guide time frame and timing of drugs.
Good follow you guys. So the ongoing drugs we discussed last time, the progressive immunotherapies, targeted antibodies, now this, are the trials now meeting where you're getting kind of the best of both worlds to actually show outcomes, or is it still like, the targeted beam radiation combined with some of the older treatments to show these outcomes, or are we there yet?
So I'll answer it from a radiation oncologist perspective, and I'll let Dr. Veach answer from the medical oncologist perspective. I think it's challenging for us because as easy as it is for us to prescribe these treatments, there are the risk of complications. In the trials, they did have grade 5 toxicities, so death because of radiation. So we have to be very careful on how we and recommend these treatments. And I think we have to do it in a way that makes sense and that is evidence-based. We tend to do it there aren't a lot of trials open for oligometastases in Ontario, but we tend to do it sort of off trial. For limited areas of progression. When we want another endpoint, that I didn't really mention was that sometimes we don't only look at overall survival, progression-free survival, but sometimes there can be a rationale for giving someone targeted radiation for an area that escapes the systemic therapy to try to delay the time till they need systemic therapy again to minimize the toxicities of that or to help the patient recover off of systemic therapy. So it's also as important of an endpoint. And so I think it really has to be a patient-centered approach. I don't know if you have anything to add to that.
Yeah, so there's some combination trials that can combine chemoimmunotherapy in the context of radiation. Like we had one trial here that's open in Coolan where they combined radiotherapy in combination with cisplatin and 5FU. Like, that's not unresectable. I think there's more apprehension probably with the drug antibody conjugates just because of their risk for IPF and like problems with the actual lungs and ILD. I haven't seen any trial that combine the two of those right now, but the immunotherapies are much more in the combined space, even for stage like 3A, 3D lung cancer as well. There's a lot more moving in for combined chemoimmunotherapy with rats.
Okay, any other questions, Dr. Zhang? Okay, listen.
Will Natalie Doherty please return to the pre-op department? That's Natalie Doherty, please return to the pre-op department. Thank you.
Thank you so much. Give another round of applause, Dr. Zhang.